So anxiety disorder is big, huge, and one of the main groups of the mental disorders, which very important to know, but especially why it is very important to know for the general practitioner, for the usual doctor. That's because these group of disorders very often remind other types of somatic disorders, non-psychiatric disorders, with a lot of symptoms which can mislead the diagnostic towards some kinds of searching of some kind of other disorders. I mean the disorders from the sphere of general practitioner, internal disorders or something like that, and that's very important to know and remember. Now, first of all, let's clarify the definitions between fear and anxiety. Fear, as you see, is emotional response for certain danger. Certain danger or threat. So fear is a reaction for something which is objective, which is somewhere outside of the person. So it can be a very dangerous object. It can be not so much dangerous objects. Maybe it can be unavoidable event or unavoidable object of threat, but it is external, it exists. Anxiety, it's the anticipation of danger. So it can be internal stimulus, or it can be something like an unidentifiable external threat. So it's an emotional response for uncertain danger. The key difference over here is that it's not exist yet. It's not in front of you yet now. Maybe that will be in the future, these events, or maybe these person you meet later, but not now. Now it's okay, but your anticipation make you feel worry, make you feel a danger. This is the key feature of the anxiety, and actually this difference gives the possibility for the psychotherapy. Very often psychotherapists try to apply so-called grounding techniques. Then they ask for the patient, look right now at the ground where you're standing out. Look around at your table or desk. Look in the window. Look around you. What do you see? What do you feel? How are you? And then patient cannot see any objective danger right now in front of him. He calms himself. That's a technique we call grounding, and it is based on the difference between fear and the anxiety. Fear is a real danger. Anxiety is just anticipated danger. Actually, it's your fantasy yet. It's not a danger. It's not a threat yet. Anxiety disorders in primary care settings. You see that's the frequency of an anxiety disorder, approximately 10, maybe 15% of patients. Quite big number. So each 10th of the patient in the primary doctor office, it's a patient with an anxiety. As you see, that approximately it's even more than the number of patients with the depression. In the comparison, to compare the prevalence of the anxiety disorders in the general psychiatric outpatient practice, we can meet them approximately in a 40% of the patients, especially outpatient, they suffer from anxiety disorders. So, and another position, then treatment of anxiety disorders can be provided by the general practitioner, family doctor, internist, And psychiatrists it will be needed only then the case will be difficult, complicated, or maybe when the case will require psychotherapy or patient would like to have psychotherapy. But most of the patients can be treated by the general practitioner, and they are treated by the general practitioner is a, you know, sorry, in the developed countries. Epidemiology. Well, anxiety disorder most prevalent among all the group of mental disorder. And epidemiology found that especially anxiety disorders maybe a bit less than depression, but also it is a very prominent impact for the social well-being. Wait a bit, somebody rose the hand. I got the questions finally. So, any question? Wait a bit, somebody have a question? You can turn on your sound. No question. Okay. I thought there was somebody raised a hand, but looks like it was just an incident. Okay. It's very costly for the society, these anxiety disorders, because anxiety disorders for the not only for the society, for the general economy of the country. Anxiety disorder lead to the losing of social and work productivity. That means economical loss. Some kinds are very, very serious. And if we calculate how many taxes, for example, this man could pay for the state if he wouldn't have any anxiety disorder. So then we will get a very big amount of money, which we could use for the health, for the social program, etc. So, and anxiety disorder now very often they lead to the suicidal behavior. They found it, and they one of the trigger of the suicidal thoughts. One of the reasons why people decide not to live anymore or don't want to live anymore in such a condition, because they have an anxiety. So this is the chart about the lifetime and 12-month prevalence in terms of the depending on the gender and the age, and as you see of a general of anxiety disorders. As you see, it's quite young people are most vulnerable for this kind of disorder. It's the maximum age in the 30s. In their 30s, they start to suffer from generalized anxiety disorder, and even in their 15s, they start to suffer from social anxiety disorder. Now let's look at the numbers. I wanted to look at, for example, the specific phobia. Well, every 10th, maybe not only every 10th, every 8th person in our society can suffer from specific phobia. That's a phobia of particular objects like a spiders, or phobia of water, or claustrophobia. But let's look at more severe disorders like a panic disorder. 4% of the population, 4%. Not one, like in schizophrenia, maybe schizophrenia even smaller number, but it's about 4% of the population. big number of the very prominent social anxiety disorder, exhaustive shying also every 10th, and generalized anxiety disorder, like a panic disorder, very stable and very prone to the chronic type of course disorder. Uh, so if we calculate all of them together, 4, 6, 16, 14, 14, 29, yes, and 35, we will get a third of the population. It's a rude calculation, but a third of our population can suffer from general anxiety disorders. So risk factors, they are female sex. As you see, a bit, not a bit, obviously, usually and statistically, obviously, women suffer from anxiety disorder much oftener than maybe they more vulnerable, maybe they more sensitive, and actually women brain structure is composed with a good, quite good ability to read the emotions, to understand the emotions. So women have a very huge, very thick pathway of the transport of the informations about the feelings. So they do detect feelings very well, the emotions, and men, they usually do not they feel emotions, they feel feeling, they have their feelings, but they do not recognize them because they have a very small flow of information. So it gives profits for the man in this case because they suffer rarely about the anxiety disorders, but it also give disadvantages for the man because they do not feel, they do not able to understand what's going on with the person, not and women much more empathetic, if you wish. So women are capable to understand you and to feel better you in this and to help better in the terms of than it is emotional support is required. Now, younger age, lack of family also lead to the chronic risk of development of anxiety disorder, poor social support, low education, and last point, stressful life events and childhood maltreatment. Actually, abuse is very strong factor in the development of anxiety. So now it is very difficult to even until now, due to even if we have social scientific new approach, if we have new methods of the providing of the scientific researches, but we still cannot prove these usually obvious for the clinicians connection between early childhood abuse and the anxiety disorders and the developmental anxiety disorders in adult persons. It's very difficult to prove it, but it exists, and now we have more and more information about that. So this maltreatment in childhood is very important, especially in the cases of abuse. Comorbidity of the anxiety disorders. In general, the comorbidity of anxiety disorders is very intensive. So what is comorbidity? First of all, the comorbidity is the case that few more diseases and other diseases will occur together with primary disease over here. So primary disease, if we take generalized anxiety disorder as the primary disease or any other anxiety disorder. So that means that very often in this patient we can find another diseases. And these are another mental disorder like personality disorder, and also what's important is the physical disorders. If the comorbid physical disorder like generalized anxiety disorder very often can be seen in the patient who also suffer from hypertension. And you see that over 90% of the persons with an anxiety disorder will have comorbid or disorders or some disorders which are connected with them. And the problem is that the comorbidity leads to the poor outcomes and affects treatment. It actually makes treatment more complicated, and we have to address our activities for both disorders, for anxiety and for the comorbid disorder. If we treat only one comorbid disorder, for example, if we treat only hypertension, there will be not so good results, and quite vice versa. So if we treat only hypertension without addressing our help to the control of the emotional condition, or to control anxiety, so there will be also a lack of effectiveness right here. Well, and comorbidity, these mood disorders like an anxiety disorders, they used to substance abuse, like alcohol, or any other anxiety disorders. So alcohol and anxiety disorder, they goes together. That's obviously why, because it's an attempt of a person to treat himself or herself with the pills in order to reduce the anxiety. And physical conditions. A bit more about physical conditions. So physical health very often suffer from, or not from, together with the mental health and anxiety disorders. And most common diseases, of course, over here, real diseases, it's a cardiovascular disease. This, besides that, anxiety disorders by themselves initiate some symptoms reminding or some hyperactivity of the cardiovascular systems, like palpitation, increased pulse, like a feeling of discomfort in the chest, breathlessness. Despite this fact, that also very often together there will be a cardiovascular disease. Respiratory illness, especially those illnesses who are really connected with the stress, and where the stress play a big role in the development or in this sustaining of the disease, like in asthma in early stages, asthma stroke usually being provoked only by the stress, and they can be treated by the used to treat it by the taking of just sedative drugs, and that will be sometimes enough to block the development of asthma. Arthritis has the reaction for the vessels, for the joints, self-attack for the joints, let's say. So because of the anxiety, it's also possible migraines. So as you see, the serious illness may trigger the onset of anxiety disorder. Anxiety disorder by itself can trigger another disorder, not another physical disorder. What is, so now we have a generalized anxiety disorder. Let's talk a bit, and then we'll make a small break. So generalized anxiety disorder, it's characterized by nervousness. That's an apprehension, somatic symptoms of anxiety and worry. So GAD is multifocal and pervasive in nature of worries. That means the worries of the patient. There will be a different types of them. There will be a lot of reasons for them. So which kind of them our brain will find right now? That is will be our worry. For example, maybe if today, what is particularly important for me, it's I don't know some kind of issues at my work. So I will be worrying about something about that can happen in my career or something. If there will be clues about health, I will be worrying about health. Maybe there will be some reasons about health, or like a COVID condition or something like that. Finances, income, stability. So these people worry about everything just to give them a chance, and they will find you the reasons. Safety and others. DSM-5 criteria for generalized anxiety disorders. So the first criteria is an excessive anxiety and worry. Apprehensive expectation, and at least for 6 months. For 6 months, and these worries exist in multiple activities. That's an examples here: work, school performance, health, safety, finances. So anything can be, but look at the over here. Look at the number: 6 months. It's a long period. So before to establish the diagnosis of before to put a diagnosis of the generalized anxiety disorder, we have to be sure that it is not just a reaction for the current life circumstances, and we have to wait for half a year. That will be enough to stop your unnecessary worrying for maybe something that was new for you. A big period of waiting, 6 months. So, and individual find subjectively that it is difficult to control the worry for him or for her. Not that's not obligatory symptoms, because very often people do not recognize it, and their family members usually can say, you have to control your excessive anxiety because it's unnecessary over here, it's useless over here, and it's not so good for you to worry about such a not so serious reasons, because everybody can be in such a danger, but you worry like it already happens. So there are relatives very often an indicator of their disease. And very important list of symptoms. Anxiety associated with these symptoms, and you see there will be at least 3 of them, maybe more, is required to develop anxiety disorder. So restless, or keeping kid or on edge. So these guys, they are really scared for. They looks like they're waiting for the bad news. They have been in charge, or they vigilant, too much vigilant, and they're ready to give a blast of anxiety, blast of fear, to give a fear reaction. They really, because they are of that, they're really fatigued, and they're difficult with the concentration, with the learning, with memory over here, irritable, with muscle tension, and their sleep is disturbed. So that's a consequence actually of the anxiety disorders, because they would sleep well, but they think too much when they try to sleep. Or what they think? They think about the probable danger situation or factors that can maybe harm them or their families. So then they analyze this probability. They try to invent the probable reaction, the probable way how to prevent it, and so it's a death circle where they think and they cannot stop to do this. That's not caused by some kinds of medical substances, or like another medical condition, hypothyroidism. And very important things, these anxiety and worry reduce, make it smaller, the effectiveness of the person by himself. So effectiveness, I mean, occupational learning or interpersonal effectiveness, or actually, well, these disorder, it maybe would be too easy, block the effectiveness and block the adjustment of the person for the environment. These are the exclusion criteria. So anxiety is not about panic attack, so there will no panic attack. It's not about the fear of negative social evaluation, like social phobia, contamination, very particular for the anxiety, for the GAD, but E only. They have some obsession and compulsion. They only have them, but nothing else. So exhaustive shine, anorexia neurosa, they're afraid of weight, physical complaints in somatic symptoms disorder. Physical complaints means they're only present with the physical symptoms. You remember somatization of affect and anxiety. Body dysmorphic disorder, they only afraid of that their body is kind of ugly or very unpleasant, and the disorder that they have a very serious illness, believe that they have a very serious illness. That's schizophrenia and other delusional disorder. Also, patient, we should distinguish that from the agoraphobia, but agoraphobia very often just complication of other anxiety disorders. And here we can see how many physical symptoms can medical practitioner meet in a GAD. So these physical symptoms can mislead for the misdiagnosing of the headache, as maybe there will be some basis or problems with vessels. And after some tests, there are findings. And then the neurologist, for example, can be in this trap, and he will continue to treat this person. But it's not necessary, because they suffer from anxiety. Back pain and other muscle pains, aches, gastrointestinal distress, very interesting stuff, because anxiety always or almost always involve epigastrial area, like area of a discomfort, maybe hunger, maybe it's a pain, maybe it's a burning. So a patient remind a patient with an ulcer or with the risk of the development of gastric ulcer. So these patients also goes for the other primary care or the specialized doctors like gastroenterologists, and there is nothing serious they can find. And insomnia, where they will go to the therapist, to the neurologist, maybe later to the psychiatrist. Well, hyperthyroidism and other substances, they also can induce this disorder. Etiology. Etiology shows in twin studies, the etiology shows that GAD and neuroticism, so-called, it's an old term which was discovered in the coinates in the beginning of the 19th century. So this neuroticism is a very heritable feature which can be passed from the mother to the child and from the parents to the children, from father as well. So neuroticism, it's as you see, that's here the definition. That's an exhaustive ability, too much the readiness, I would say, to be more moody and experience within the other people and experience often and more intensive feelings, anxiety, worry, frustration, and jealousy. So these people, they really prone to be fall into the emotional conditions where the emotions just exist in their soul without control, and actually it is an emotions which actually control the person, but not vice versa. So neuroticism, it's a genetic feature. It's go from the parents. Yes, but neuroticism is also a good feature because neuroticism make a person interesting, make a person emotionally interesting, not a robot. Otherwise, why do you need a robot to be a friend or for the conversation? That's not, he's not interested. People who are neurotic respond worse to stress and more likely to interpret ordinary situation as threatening. And well, they maybe would live more effectively, but they too careful for the even neutral events. For them, it can be a danger. The anticipation of danger, it's again the feature of neuroticism or neurotic personalities. Mhm. So this is pathophysiological, one of the pathophysiological explanation. Yeah. So you see here there are some evidence of failure. I'll try to. Yeah. Of failure of anterior cingulate activation to the amygdala. And actually, anterior cingulate cortex, this is, it's a cortex which suppress here amygdala and a bit hippocampus, normally suppress, normally gives a negative feedback in terms, then anxiety is being recognized as unnecessary. So our thinking like calm down, that's okay. No danger over there. So this is a normal mechanism. Then how it is work? It suppress amygdala and suppress all the other emotional reaction for the anxiety. And in this case, in case of GAD, this mechanism is poor. It's not so developed, and we have to improve it. We have to do something to help for this mechanism to restore its activity. Panic disorder. Okay. Before move to the panic disorder, let's make a small pause. Okay. A small break, and then we will continue. Okay. So, panic disorder. Another names of the panic disorder, it's soldier's heart, neurocirculatory asthenia. Well, there are a lot of names you can hear, and old names, very old names. Soldier's heart, this term was coined after World War I. So it's 2014, 1214, 1218. After these events, there was a lot of soldiers who were suffering from panic disorders, and most of them had complaints or on a increased palpitation of the heart, so-called something would reminds a heart attack, but it's okay with their heart, and that's why they call it soldier's heart. So panic disorder, it's a truism, like it consists of panic attack. Yes. So what is panic attack? And here, this is the definition of it. Panic attack is a sudden from the blue episode of severe anxiety, very intensive anxiety, like somebody said, for the anxiety you have 10 minutes to show yourself, only 10 minutes left for you to leave with your whole life, and it goes out for the, I don't know, for the enormous party, and then after it has been functional and fully active for 50-20 minutes. That's so not so much time, and that's why anxiety takes everything that it wants, and it presents itself enormously. And very important one thing, that not only panic, psychological component, it's also accompanied by the array of physical symptoms: cardio, respiratory, motor, neurological, gastrointestinal, autonomic. So all these combination together with panic, it will be a panic attack. Panic attacks are extremely frightening. Yes, a person thinks that he will die, she will die. And patients after panic attack, they're usually really tired because all the resources have gone. It's not included as a part of, yes, of the diagnostic criteria. Yes, that's true, but very often symptoms, and very obvious and logical symptoms, because people really, really very tired. Although they need time to restore their condition. DSM criteria. So it is required for the panic attack that it would reach for the maximum, see, discomfort, actually panic attack, reach peak for the minimum for the few minutes. And during these few minutes, during this period of panic attack, we should, not 3 minutes, but more, of course, we should find 4 or maybe more, maybe all of these symptoms. And what are they? Palpitation, pounding heart, accelerated heart rate. These are the symptoms of the sympathetic activation, just only biological. Sweating, again, sympathetic. Trembling or shaking, it is. Again, sensation and shortness in breath and smoothing. Same. A person is feeling that he is dying from the lack of that he can die from the lack of oxygen. Enough, no other ideas he has. In this case, feeling of choking. Because of the spasm over here, and because of the feeling of airlessness and pain or chest discomfort, which reminds a heart attack. So nausea, abdominal distress, dizzy, chills, paresthesias, a number of tingling sensation, but not only, it's like a paralysis or with movements, with cold, maybe with the heart. So, and derealization. So reality is blur, unreal, is being changed. Well, that's mostly, of course, because high level of anxiety, high level of internal concentration, and the depersonalization also can be present. That the same thing. The person does not recognize himself. Just something wrong with me, something wrong with my psychic, with my experience, with my even with the conscience. So they don't feel themselves as themselves. They can change as if somebody changed me, as if somebody suck out life, conscience, mind from me, or if somebody had been caused, if keywords is if they say that somebody really did it and they really believe in that, these are the delusions, and these are the maybe schizophrenia or delusional disorder. Feeling of losing control, of going crazy, and madness is coming because they cannot control, and fear of dying. Next criteria, that's at least one panic attack was accompanied with the concern, worries about the future attack or about the consequences. So they don't want to have this anymore. Nobody wants to have this anymore after they survive from this. It's a very shocking condition, this panic attack, and the person really think about it and only think about it and afraid because they don't know what was it, and they're afraid that it will happen again. They have to do something to prevent that. So panic attack can be can lead to the change in the behavior which is related to the panic attack. For example, the behavior or the day is planned in order to avoid a panic attack, avoid some situation that can be per person can be believed that the somehow connected with the panic attack, that they can trigger the panic attack in him, or the person avoid of unfamiliar situation because he think that if he would worry that so he would have some panic attack or heart attack. And of course, we have to exclude the substances, drugs or pills, both of them possible to cause this kind of, no, not this kind of panic attack, classic panic attack, hyperthyroidism. Hyperthyroidism means too much thyroid hormones or treatment with thyroid pills. Very often, if the dosage is inadequate, that can be a problem with that. And these are the exclusion criteria. Exclusion criteria are about that the panic attack is not because of the social situation. It's not social anxiety disorder. So people, it is not caused by excessive worrying that other people will laugh on me, shine from myself. It's not a response for the phobic objects like dogs, blood, or something which cause a particular fear, and only these situations cause particular fear. There are usually one, there is usually one or maybe two, not more than 3 phobias in a person can exist. So this is not that. It's not an obsession like I have a COVID, I have to check my health. Wow. Only that. It's not about traumatic events like a previous trauma, which goes into the mind again, returns back refreshed in the mind. And it's not about the problem of the separation from parents, like in a separation anxiety disorder. Very often people can change their attitude for the life because of the previous panic attack, and they afraid to leave their home. And you see that's a pervasive phobic avoidance developed, and we call it agoraphobia. Yes, so people afraid to leave a house because they can have a panic attack, because they can these people believe that it's a heart attack or something like that. So they're afraid to be somewhere outside of home without help. And this is the most common complication of panic attack, this agoraphobia. In general medical condition, yes, panic attack mimics a lot of disorders, a lot of other the usual medical disorder, like and these people go to the healthcare facilities, they check, they have a laboratory test, They go to ultrasound from one professional to another professional, to an isolated professional, not isolated, with one professional in a specific area, like a cardiologist. Then they go to another professional, like a neurologist. So they travel from one doctor to another. And so the problem is that, yes, they believe that they have a serious physical illness, and it's normal, actually. Then a young person, starts to have a heart attack from the blue, walk in the street. We have to first of all check him, and then we do not find anything. We have to explain him and give an education, yes, about his condition. Sometimes it don't work, but sometimes it works and it helps. So in the beginning, usually patients come not for the psychiatry, they come for somebody else, some other professional. So comorbidity. What? Because the panic attack can be the results of other disorders. We have to rule out these disorders. Hyperthyroidism, very often. Caffeine, not so often, but caffeine misuse. I mean, as that should be very, very intensive. Misuse, not so often the case, but hyperthyroidism, especially drug-induced hyperthyroidism, that's about that can lead to the panic attack. So we have to make a thorough medical history, a physical examination, hormone blood level. So we have to make a blood drug screen in order to rule out these kind of disorders. Panic attack leads to the frequent palpitations, yes, to the Holter monitoring. And there is a profound confusion after attack. But sometimes, not sometimes, it's possible that the panic attack can initiate another disorder. And in this case, we have to be vigilant. If course of illness, I mean panic disorder, is being changed and they become atypical, or become and a bit another, not as usual as possible, already habitual to that. So if it is different, so we have a problem. We have to look, and most probably we will find something. And of course, in case of if a patient do not respond for the standard treatment. Etiology. Twin studies found that it's a quite heritable disorder. Panic disorder, 40%. Quite heritable, not moderately actually, heritable disorder, because if it would be heritable disorder, it will be at least more than 50%. And there are a lot of theories which explain the appearance of these disorder, and let's move to look at them. Neurobiological experience. First experiments of Pitts, he injects sodium lactate for the volunteers, and there was symptoms like a panic attack. Also, panic attack can be induced with caffeine, either proterenol, yohimbe, carbon dioxide. Okay, so all these stimulators can also lead to the panic attack. But many, you see, a good explanation depends on the functioning of brain fear circuit. And they believe that in a panic disorder, that's very important component of the development. In this picture, you can see that the amygdala, yes? Amygdala is become a very sensible, very, very sensible, and it become too activated to dominate it and play a crucial role in the development of panic disorder. So amygdala, as you see, it is gain an information from the sensory thalamus, hippocampus, sensory cortex, from all the type of cortex. So this information goes to amygdala, and amygdala, because of it is because it become too sensitive, like vulnerable, and too reactive, overreactive for any neutral event stimulus. It activates sympathetic nervous system. You see there go to adrenal glands, autonomic pathway. But what is interesting that after that, this information, this activation or information about this activation, for example, goes again to the sensory thalamus and then to the amygdala, and amygdala again, powerful amygdala again get a signal, please activate me and save our life because something is wrong over there. Psychologically, what's going on in a panic attack? Psychologically, we got a learning theory which telling us that lines of bodily sensation, so means too particular, too intensive, too much vigilant attention for the sensations from the body. These particular attention suspend or maintains the panic disorder. How is that? Because of this interoceptive hyperattention, yes? Attention to the sensation, usual physical sensation. Now, after this attention is increased, the usual physical sensation, now they are capable to be detected. Before that, we didn't pay attention for these physical symptoms. We had them, but we didn't pay attention because that wasn't important for us. But now, then we scan ourselves, am I healthy or not? It's okay with me or not? Let me check. I have some businesses to do and I have to be sure that it's okay with me. And we scan our body, and then they scan their body. People with panic disorder, they usually find something. And this something for them can be the reason for this kind of these sensations, can be the reason for the fear. And fear, again, suspend the general level of an anxiety. And in this case, you can see the loop, pathological loop. I pay attention for my condition. I found something. It caused me to think an anxiety. Anxiety increases, and now I can see it more intensively because anxiety increases all my feelings, and anxiety also directly activates my sympathetic nervous system, and I am collecting more and more anxious signal that something is wrong, and then I will have a panic attack. Oh, like you see, it's all over here in these symptoms. So life stress, perception of change in the bodily condition, and then we have misappraisal of these normal sensation as dangerous. Then it goes to intensification of these sensations, and again we perceive them as more pathological, and we got a hyperarousal condition, hypervigilance, and we avoid of the events. And this avoidance actually by itself stimulates the development of panic attack. Then you avoid something, then you are in a safe place, like in a house or somewhere like that. What can you see? You sit in your safe position and you're afraid of anything new. You're afraid that there will be any change in your very comfortable position. And the problem is that these changes, these challenges, they would be for sure. And it's impossible to sit in a protected place for all the time. Well, then now it's agoraphobia goes. We will talk a bit. We will start the next lecture from this topic. Now,